It is my great pleasure to welcome you to the 19th session in a series of social service workforce webinars that are funded by the President's Emergency Plan for AIDS Relief, or PEPFAR, and implemented under the auspices of the Global Social Service Workforce Alliance by USAID Partner for Children. As Chris indicated, my name is Mari Mendenhall, and I am a Senior Technical Advisor for Orphans and Vulnerable Children at the U.S. Agency for International Development's Office of HIV and AIDS. And I also have the great pleasure of co-hosting this particular webinar with David Chapanta, Senior Advisor for Social Protection at UNAIDS, and Anita Sampson, our Interim Senior Advisor for Orphans and Vulnerable Children from the Office of the U.S. Global AIDS Coordinator and Health Diplomacy at the U.S. Department of State. Today's webinar will focus on celebrating success in social service workforce strengthening in honor of World Social Work Day, which is tomorrow, March 17th. And more specifically, this webinar will highlight the role of the social service workforce in supporting HIV-affected children and families and contributing to clinical outcomes and the goal of ending the HIV-AIDS epidemic. We know that significant reductions in new HIV infections, AIDS-related deaths, and HIV-AIDS-related discrimination are only possible through a well-planned commitment to prevent and to mitigate the social, economic, and mental aspects of HIV. A strong social service workforce engaged alongside others to increase access to HIV services and psychosocial, nutritional, legal, and economic support is essential to this effort. For nearly a decade, PEPFAR has invested in initiatives to strengthen the social service workforce through helping partner governments and other stakeholders to better understand the workforce and make plans for a stronger workforce, training workers in the skills that they need to do their jobs well, and improving mechanisms for supervising and supporting the workforce to prevent burnout and enable workers to perform to the very best of their ability. In several countries, these efforts have begun to generate some really impressive results. And today we will hear about these results from PEPFAR colleagues in 3 countries. Sagai Tilahan, Technical Advisor for Orphans and Vulnerable Children and Household Economic Strengthening at USAID Ethiopia, Colin Maragwanika, Orphan and Vulnerable Children Specialist at USAID Zimbabwe, and Dionisio Matos, Community Care Team Leader for the Integrated Health Office at USAID Mozambique. We are also going to hear from our colleague and co-host David Chapanta about UNAIDS-supported initiatives to engage and support social service workers. And Anita Sampson will close our webinar with a few final observations and a few closing thoughts. Each presentation will be followed by an opportunity to engage in a short question and answer period with our speakers. And we will reserve some time at the end of our session for a brief discussion involving all of our presenters and our hosts. So as a reminder, please feel free to write comments and questions in the chat window throughout the webinar. I will keep track of these questions and I will present them to our speakers after each presentation. So at this point, please join me in welcoming David Chapanta for a few opening remarks. David?
Thank you very much. It gives me a great pleasure to participate in this important session. Tomorrow, March 17th, 2015, is World Social Work Day. I'm very glad that this year the social work organizations with their over 2,000 schools of social work and over 500,000 social service workforce across the world have invited UNAIDS to celebrate this important day. I'm glad that UNAIDS is joining PEPFAR IntraHealth International and for children at this important occasion today, March 16. It's very clear for us in UNAIDS that the social service workforce plays a critical role in our mission of zero new HIV infections, zero AIDS-related deaths, and zero AIDS-related stigma and discrimination. We have many practical examples where the social protection programs and the social service workforce have been the lifeline for people to access life-saving HIV services. I'll give you a couple of examples. In Kenya, Malawi, South Africa, and many countries in East and Southern Africa, social protection, including cash transfers, have not only kept orphans and vulnerable children, including young girls in schools, but have reduced new HIV infections by 60% in one study in Malawi, and reduced HIV risky behaviors in South Africa by 70%. We know that when we combine social protection, including cash transfers, with psychosocial support, good parenting, teacher support, or activities that the different cadres of the social service workforce provide, HIV prevention effects are multiplied several folds. In Morocco, Association de Lutte contre le Sida, ALC, works with social workers and the Ministry of Social Development to assist people living with HIV to remain and adhere to HIV treatment by meeting their transport needs, basic housing for when such people come for treatment, and meeting their overall psychosocial needs. In the former Soviet Union countries, including Belarus, Georgia, and Ukraine, and most high-income countries, it is the social service workforce who link people who injected drugs, migrants, people who are homeless, and people living at the margins of society to access clean needles and syringes, opioid substitution therapy, critical HIV services, and broader social services such as vouchers for gas, for heat, and in some cases short-term employment, housing, food, transport, and so on. We believe in UNAIDS that we can harness the power of effective social policies and social protection programs to truly end the epidemic for all. And we believe that the social workforce, the social service workforce, can help us, especially in the following 3 ways. Number one, you can join us in ramping up proven social and structural interventions to prevent the alarmingly new HIV infections, especially among young women in East and Southern Africa, and focus our interventions on locations and populations that are left behind. Number two, you can increase the quantity and quality of social workers, the different cadres of the social service workforce, and deploy them to areas of greatest needs and where people can access these critical services. Yes, we need the doctors and nurses, but we also need good social service workforce who can connect people to services and make services work for people. The third one is you can help us to intensify focus on social justice, inclusion of populations that are most marginalized, and restoring dignity to people that are left behind. With your help, I am very convinced we can achieve the 3 zeros for everyone, everywhere in our lifetime. Thank you very much.
And thank you, David. I know that many of us are looking forward to your event tomorrow, and we'll be logging in to hear from you again. Thank you.
Excellent.
So we're going to begin with our first speaker, and that will be Colin Mararonika. Colin's going to talk to us a little bit about some of the exciting developments within workforce strengthening in Zimbabwe. Colin, are you ready to begin? And just as a reminder, if anything that Colin says really sparks your interest and you have a question and want to hear more, please feel free to write your questions in the chat window, and I will write those down and he will respond at the conclusion of his presentation. Thank you. Colin?
Thank you so much, Maureen. Hope everyone can hear me. My name is Colin Mararonika. I'm presenting this from Zimbabwe. I'm the orphans and other vulnerable children specialist. In Zimbabwe, basically the mandate for children's welfare issues lies within the Ministry of Labor and Social Welfare. And this mandate comes from the Children's Act, and they are mandated to design and implement measures for addressing child vulnerability. Previously, it was the Department of Social Services, which was split in 2014. into Department of Social Welfare and the Department of Child Welfare and Probation Services. So just some little bit of background in terms of the situation prior to our intervention. We had HIV prevalence at around 13.71, that was around 209, and then orphanhood estimates were varying between 989,000 to 1.6 million. So the 1.6 million at times includes other vulnerable children, not necessarily orphans as well. So, and then we had a difficult economic environment which was limiting the Department of Social Services capacity to deliver on social protection mandate. And then we have our training school which trains social workers. Again, it was resource constrained, and it was failing to supply the required number of social workers. And then in 2009, 2010, there was an institutional capacity assessment of the Department of Social Services in Zimbabwe. And then what sort of came out was we had a 24% vacant rate as of June 2009.
Tomorrow, March 17th.
Yeah, hello. And then that was in terms of posts in the Department of Social Services. Then in terms of social services officers, and these are the guys who really do the running around in terms of children's issues. So we had a vacancy rate of about 37%. And then we were having a situation where we could not really, the government could not really run proper induction program for its recruits. You just come in from college or university, and then you are just posted. So that was a big challenge. And then continuous professional development within the department was a challenge. And then in terms of this whole thing resulted in a high dependency, high ratio of a social worker per, and a high number of children per social worker. And I sort of brought in our neighbors there just for comparison purposes. So in Zimbabwe, we had one social worker looking after almost 50,000 children, while it's in a country like South Africa, they were looking at about one social worker would look after about 1,250. So this whole thing had a negative impact on children. When we talk children, we can't separate them from social workers. Social workers and a functional social welfare workforce system go hand in hand. So we were introduced as the USAID Zimbabwe to social welfare strengthening through the Social Welfare Workforce Strengthening Conference in 2010. And then from that workshop, we sort of, in that workshop, we had UN represented by UNICEF, and then the government itself was represented by a deputy director, and then we had someone else from Save the Children. And then from there, really, we sort of came back as a country and we sat down and we partitioned what we could do as USAID, what the UN could do, and what other players could do. So I'll focus on what we did as USAID. Number one, we really looked at the helping the Department of Social Services to come up with a strategic plan. This was a 5-year strategic plan just to help them focus on strategic priorities in relation to issues relating to child welfare. And then it's critical that we have a trained or a skilled workforce. So we supported 25 graduate officers with no social work qualification to undertake social work diplomas. So what was now happening was, in the department, whilst we are saying social workers are critical, in helping out children. Because of all those problems, the department was even recruiting people with non-social work degrees to work as social workers. So we took about 25 of those graduate officers from the district, and then we helped them through a local university to attain diplomas in social work. And then below them, we have the social services assistants, and we also helped about 40 of those to attain a certificate in social work. And then we also had about 10 officers doing a postgraduate diploma in child-sensitive social policies. And then we also were working with the Department of Social Services and the National Association of Social Workers for a graduate partner internship program. So we were saying as the National Association of Social Workers, they could mobilize some of these newly graduated and at least make sure that there are some bodies on the ground. And then in terms of what I'll say a key intervention which we supported together with our other developmental partners, we helped the government set up a case management system. And this system is anchored on training volunteers into community child care workers. And we are saying, or research shows that if you have this sort of support system which identifies children's issues and then initiate referrals and follow-ups, then you are sort of be able to catch up on most of the children's issues. And then more about this cadre, the community child care worker. These are volunteers based at the lowest level, at the family level or at the village level. So they interact with families and children on a daily basis. And then this to us ensured that the Department of Social Services has a functional child welfare system from national to the family level. These community care workers work with the district social welfare officers. And then what we have also seen, this case management, sort of put us ready to achieve the UN 1990 treatment target. 90% of the people should know their HIV status, and then for those who need treatment, they should go on treatment. So for us, we see the coming in or the strengthening of the social welfare system through these social workers being key in mobilizing children for testing. They sort of identify children with symptoms suggestive of HIV infection, and then key to that is negotiating with primary caregivers to take identified children for HIV testing. You will appreciate that in terms of child protection, they have to be guardian consent or parental consent for the child to be tested for HIV and AIDS. And then, so for us, the OVC program, whose goal is to alleviate the impact of HIV and AIDS on children, we are saying in 2015 we plan to have almost 43,000 children in 17 districts tested so that they know their status. And then we are saying from that 43,000, maybe 17,000 of them may be commenced on art. Then another key role which we are seeing under case management is adherence support. Yes, there is quite a lot of research which supports the fact that once you have this psychosocial support, family support, then in terms of adherence, we can achieve quite a lot. So again, that's what we are seeing on the ground. As we strengthen the social welfare system, we are seeing quite a lot of positives in terms of adherence support. And then currently we are monitoring about 2,000 children on art in those same 17 districts. And again, those community child care workers play a critical role. And then in conclusion, I would want to say all our efforts in focusing on HIV and AIDS amongst children, all our efforts in strengthening the social welfare system has really brought us huge positive results in child outcomes in terms of HIV and AIDS. We are seeing more children being referred to HIV services, and then for those who are tested or those who remain negative, we manage them in terms of making sure that they remain negative, and then for those who are positive, how do they get on to treatment. So in conclusion, that's my presentation. Thank you so much.
Colin, thank you so much. I'm thinking back to 2010 when you and I first started talking about these issues, and I just never would have imagined that this would be possible. It's very, very exciting and inspiring. And I do hope that if you have questions for Colin, that you will write them in the chat window, and I will make note of those and present those to Colin. Since we don't have any questions right now, perhaps I can start with my many questions. Colin, I wonder if you could talk just a little bit more about the relationship between these community case care workers and the health workers that work at that very, very local level to address health issues. What does that relationship look like, and how do they work together on a day-to-day basis?
Yeah, I would say at times it's an interesting relationship because we are seeing some of the health workers opting also to be community child care workers. But the way we structured it is like that. Is like the health worker is like a specialist. The child community care worker can also refer some of those issues to the health worker, and then the health worker, depending on the issue, can either refer to the nearest clinic or health center for further management. But if it's an issue which they can manage, they will solve it at that level. So the relationship is that a health worker is at a higher level than a community child care worker, and they receive referrals from that lower level.
Excellent. Well, I know, I see we are getting some questions now, Colin. It looked like there are lots and lots of people that were inspired to write questions. Everyone's writing them at the same time. Let's start with Rebecca. Rebecca first, and she is, and she's asking, let's see. Colin, you presented information on the existing social service workforce to the social service workers to child ratios. Can you say a little more about either the ratio of community child care workers to trained social workers and or the ratio of the community child care workers to children? Also, could you say a little bit more about the hours a week or how many clients the volunteers are expected to work, or how many volunteers, clients the volunteers are expected to care for or work with? Lots of questions.
Yeah, okay. Yeah, for the volunteer worker at the community level, basically we are saying, because it's purely volunteerism at the present moment, although the government is thinking about setting up a proper structure, but currently they are volunteers. So we really don't want to train them. We don't want for them at the end of the day not to do their other daily work whilst concentrating on this, on their voluntary work. So roughly in terms of ratios, we are saying one community child care worker can work with around 10 families, roughly. But we feel that that's not training. And then in terms of social worker, their ratio to the number of children, what I'm also happy to announce is that through the efforts of the various players, we have managed to exert quite a lot of pressure to the Zimbabwean government, and recently they opened the freeze which they had on the recruitment of civil servants, and the department has been able to recruit social workers. But unfortunately, I didn't bring the number, the exact number of the ratio now, but the ratio of a social worker to the number of children is significantly gone down through the efforts of the government of Zimbabwe by recruiting more social workers to the Department of Social Services.
Great, Colin. We have 3 more questions. I'm going to present all 3 of them to you, and then I think we're going to have to stop with questions for Colin. But again, please do keep writing your questions in the chat window. And during the next presentation, Colin, if you want to add any additional information, go ahead, and you can do that in the chat window. And during the next presentation, which will be Denise's presentation, if you are inspired to ask questions along the way, please go ahead and do that so that we can make sure that yours is the first we present to Dionisio during our next question and answer period. So really quickly, Colin, there was a question about unaccompanied minors from Zimbabwe found in South Africa and how organizations in Zimbabwe are working to address these issues and to support these children. Also, there was a question, Ochi wanted to learn a little more about referrals between the community care workers and the health workers, and are those referrals bidirectional? How does that work? And then finally, Kelly wanted to know a little bit about the community case managers and whether they were government employees, even though they're volunteers, and how, at this point, you're able to motivate them if they are volunteers, and is the government inclined to hire more of them? So lots to address there, and please.
Okay. In terms of referrals, okay, let me start with the community case care worker. In terms of case management, as I said, these are they are volunteers at a village level, and then in terms of their management, at the district level, we have a structure where we have a district social services officer, and amongst who also manages a district case management officer. So that position is the position now which sort of links up all these or looks after all these community volunteers. So for referrals, this is the position which manages those. And then in terms of their motivation, we've recently, I think they got some bicycles. Yeah, I think that's a big thing which I can mention. But the government is sort of looking at a overall volunteer policy, trying to come up with an overall volunteer policy which touches almost everyone. Because besides these community case, child case care workers, we also have village health workers, we also have family planning promoters. So all those people, the government is saying, okay, the playing field is becoming crowded, let's see how we can sort of manage those. And then in terms of referrals, yes, it's up and down, because there's also case conferencing. Once a case is referred upwards, for example, it might involve, if it's a child protection issue, say the police, the health guys. So at one time they need to do some case conferencing and look at the case, and then they always make a follow-up to make sure that that particular case is closed. So there will be a case file, and then all the activities being monitored, and then once the issue is solved, then it's closed. Then in terms of unaccompanied children, yes, that's a big issue which we have in Zimbabwe, but what we are trying to do is look at the root causes of why we continuously have children going, especially to South Africa unaccompanied. But I know an organization like Save the Children, together with IOM, those are the guys those are the organizations which are really into that particular sector. In brief, that's what I have.
Colin, thank you very much. You've done an excellent job of presenting all of the wonderful things that you're involved in Zimbabwe and responding to these great questions. So now we're going to hear from Dionisio, and Dionisio Matos is a colleague at USAID Mozambique, also involved in some very exciting work there. Dionisio, please tell us more.
Hi, Maury. Thank you. This is Chris Horvath speaking. I've been working with Dionisio on his audio issues, and so we have not resolved those as yet. Earlier when he logged in, his microphone worked, but since then his speakers aren't working, so I don't know if we can get him to talk without being able to hear anything, but I'm chatting with him now to see if his microphone works.
I wonder if perhaps we could go to Guy's presentation, and then you could continue to work with Dionisio, and then we can come back to this presentation. Does that work? Guy, are you ready to begin? Guy, would you be willing to begin your presentation?
Yes, can you hear me? Hello?
Perfectly, loud and clear.
Can you hear me?
Sound great. Yes, go right ahead.
Okay. Okay, great. Thank you, Mari, for your kind introduction. So I'm going to present actually for our experiences for our PEPFAR investment and our experience on social work development in Ethiopia. Yeah. As I hope Ethiopia currently actually economically there is some progress on economic development, but when you see the social service system and the constitution are actually underdeveloped, and resulting actually the provision of social service to vulnerable population is very challenging. And historically, when you see actually the social work profession in Ethiopia actually it was opened actually as a school in 1959, and unfortunately because of the political ideological problem actually it was closed in 1974, and it was reopened actually on end of 1991, and because of this actually there is a huge actually huge gap on the social service workers as well as actually the demand. And I can say that most of the PEPFAR programs as well as the government social service provisions actually, I can say more than 90% actually covered by the community volunteers. Those who they don't have any training, they don't have any that much experience to provide social service workers, and it's very tough for them actually to give the case management and other related activities. So the role of social service workers in our country, they handle actually case management and referrals, they can collect information and reporting, and they also actually, as I mentioned at the beginning, we have many community volunteers, and they don't have any person who provides technical support in the supervision. So the social service workers actually provide supervision and support for community volunteers, as well as they provide technical assistance for community care collusion. This is a new government structure which is found actually, which is established as a ground, and they do actually a lot of social service workers voluntarily to provide different services for OVC and as well as HIV and other vulnerable populations. And the other thing is they advocate as well for vulnerable population in the service they require. And additionally, they give awareness creation and promote for wellness of vulnerable population. Additionally, they mobilize additional resources, particularly to give response for OVC, HIV, and other vulnerable population. And having said this, those are some of the major roles actually. There are a lot of roles, but I just mentioned, I highlighted some of the major roles for them. But the difficulties is still continue. You can see number one is actually workload. You can see one social service worker responsible for more than 1,000 cases in our scenario. Imagine, in 2010/11, UNICEF actually, they did just
Guy, we seem to have lost your audio.
And now, can you hear me?
You're back. Go right ahead. Thank you.
The workload is one case, and you can see that currently our estimation actually, we don't have that much data, but our current estimation is around 1,500 days C, days W and above. Imagine for 90 million people, for more than 5 million OVC, more than 1.2 million actually, they are OVC due to HIV, and we have also more than 700,000 PHA. For this, we have only around 1,500 days C and above. And there is no standard guideline in job description, and they are very busy and they are responsible with different administration and related activities, even the existing social service workers, professional and as well as non-professional as well. So there also they are required, social workers required for complex social problems, there are economical problems, social problems, psychological problems. So they are the one actually they handle all these things, so that it's a very complex social problems are faced by their frontliner workers. And there are few incentives to work as a social worker when compared with, by the way, other professionals. And most social services actually provided by community volunteers with limiting training, as I mentioned, and burnout actually is high among the social service workers. And the difficulties, and the other thing is actually the resource allocation for social service sectors are meager when compared with agriculture, education, and health in our country. And the other one of the challenges, actually is the capacity of our organizations as well as professional associations as well as the government social service like MOLSA, Ministry of Labor Social Service Affairs, is their capacity actually very weak. And the other receive little support and supervision from improved performance and no job training for social service workers when compared still with other health workers. And those are the above what I mentioned. The above one is actually the challenges and also some of the roles. And what is the PEPFAR response to actually minimize or to contribute for this social service workers and also the workforce development? And I can say that the turning point was actually the Cape Town meeting in 2010, and that is the turning point for us. So the goal of this project actually is to improve the quality and increase the number of social service workers, particularly at most local levels, in order to improve quality access service, including HIV services. And after that, actually, we established the National Social Service Workers Task Force, which is chaired by the government. And we conduct actually an assessment of social service workers. It was actually conducted by IntraHealth in collaboration with UNICEF, which is a PEPFAR support. And we adopted, as I think many globally actually, Ethiopia is known with the health extension model for social service workers development. We used that and we adopted actually for our response. PEPFAR is actually adopted that. And we launched it actually with this project with ESWA, which is the Social Work and Sociology Association, Professional Association, in collaboration with the government. The TVET means the Technical Vocational Education Training and local universities. And we actually launched in 2013, October 2013, to train 4,000 social service workers to give a service for HIV, high HIV and OVC burden areas quite. And what is the key achievement for the key achievement so far? And Ethiopia is actually, the government of Ethiopia developed and approved actually the social protection policy with our implementing partners, that's SY, and also with PEPFAR, we influence the government and clearly included actually this social service workers development in the new social policy, protection policy. And the government has envisioning actually to plan to deploy 2 social workers at Kabale level. That's when you say Kabale is the lowest administrative unit. It's a very great achievement for us actually. Of course, it's a little bit ambitious plan that the government is committed actually for the future to deploy 2 social service workers as a lowest government administrative unit. Another thing is we conducted national level policy, especially to give awareness, to create awareness and also sensitization workshops for our different stakeholders, donors, as well as the government ministries to actually to give highlights and also data about how it's a very big problem on the social service workers. Another thing is we tried actually to provide capacity building for MOLSA and TVET actually for this professional association, the Ethiopian Social Work, Sociology and Anthropology Association. And the other thing, key achievements actually rolled out, we rolled out as a national occupational standard for the new careers of social service workers. This is for the first time, by the way. Of course, the government developed this one, but actually was not actually rolled out to the TVET, the training centers and the universities to use this occupational standard. And we introduced a new and improved social service workers training curriculum as per the occupational standard. This is a great achievement for our implementing partners, for PEPFAR as well as for the government. And additionally, we leverage government resources to support training. The training centers are government institutions. Teachers are employed by the government. The PEPFAR has actually allocated a very small amount of money for this project. And it's a 3-year project, and so it's a very small amount of money. It's very difficult actually to train 4,000 parasocial workers with that money. So we leverage government resources to support the training, and the government is actually willing. And the other great thing is actually we secured agreement from the JOE, from the government of Ethiopia to employ all trainees. That is a great thing, because if the projects can employ these social workers, but if the projects are change their life of time, it will be actually not sustainable. Now, as I mentioned earlier, we use actually the health extension model. So the government actually agreed before start the training to employ all social service workers cadres. And the results, so far with that, as I mentioned, the project is started in October 2013. So far actually we trained 787 social service workers, have graduated and employed by the government and serving vulnerable population, mainly actually orphans and vulnerable children. And they deployed actually on a high HIV prevalence area and also high obesity burden areas. And the 901 will graduate in June, and the additional 2,392 actually will be finish the training in June 2016. So at the end of 2016, we'll have actually 4,000 social service workers at level or level 2 level. This is the first time actually Ethiopia has such kind of So the other is we supported 23 TVET teachers to take the competency of the certification to provide actually the training. And this is a national, we supported as well the 23 national level assessors. This is a national assessors actually, they are a kind of TOT. They provide actually training and also provide certification for the 23 TVETs, the social service workers teachers. And what's the impact? Just to highlight this, two big impacts actually. Increase the demand for HIV testing. You know that especially in our country, obviously currently is one of the highest yield population, and this obviously actually they should be get treatment, they should be tested. So I think this is we are very happy actually the demand for HIV testing is increased because of the workforces. And the other thing is improve adherence among HIV positive children and caregivers. This is another impact so far. Our best practice actually, as I already mentioned at the beginning, is we involve the government from the beginning. That means the mandated ministry, that's MOLSA, Minister of Labor and Social Affairs. This is the mandated ministry. Of course, Minister of Education as well as actively involved, and Minister of Health as well actually. And we use data first, and instead of rushing to the training, we actually conduct the data that we need evidence to convince the government, to convince our other stakeholders, and that's the HR assessment. The findings, and we submitted the findings, and the government actually accepted and approved the findings. Based on that findings, actually we started our trainings and also design projects. And we look for the successful model while already tested and accepted model, that is the health extension workers model. So we use actually successful models for a familiar to the stakeholders. The government is actually, they know that model, so they are accepted actually when proposed to use the health extension workers model to the social service workers to train the social service workers. The other thing, we engage with local partners. We are actually special. We award actually the professional associations and the School of Social Work. Actually, we actively engage for this project. And the other thing is we are cost effective. For this 6 months training for level 2, it is $300 actually for 6 months, and almost $50 per month per training. It is by the way, it's cheaper than when we see the health extension training and other workforce, similar workforce development training. An ongoing challenge, as I mentioned, actually now the PEPFAR resource actually become decline, and we will face actually significant resource constraints. And you can see the mismatch, the significant mismatch between the demand and also the supply side. And additionally, the government actually, there are competing development priorities, especially in a country like us, like Ethiopia, highly under-resourced country, and the high turnover is our ongoing challenge, and inadequate capacity of the government, the training institution, and professional associations actually. There are some of the ongoing challenges to fulfill the workforce development, what the community and the vulnerable population is demanding. And our future plan, although there is ongoing challenges, our future plan is actually, we continue our work with the government to allocate funding for social service workers training and deployment. We also strengthening partnership with other donors and CSOs. We actually started to discuss with World Bank and other donors, bilateral donors, and we'll work closely with the new initiatives to mobilize the resources like the new generation PSNP. The PSNP, the Product Safety Program, is a flagship program of the government of Ethiopia. Many donors actually allocate money for this Product Safety Net program, mainly focusing for food security activities and initiatives, but previously the PSNP program was focusing on rural areas, but now they have a plan actually to include urban areas. That means that will be addressed actually OVC and HIV. So we will work closely with the new initiatives to mobilize additional resources for the training, and they are happy actually we started the training. We started the discussion with them. And the other thing is we strengthen the relationship between colleges, universities to provide quality training and supervision. We will continue actually to build the capacity of professional associations and government. We will conduct evaluation/research. We want actually to more data the contribution of the new CARDES deployment for epidemic control and other social problems that will elevate by this CARDES, and also we can actually mobilize the resources for with data. We can mobilize the resources. We can convince the government to allocate additional money, and the scale-up training will be other regions to the country. Now we only focus on few regions, that means 4 regions, but based on the data, we will actually scale up our the training in collaboration with the government. So,
guys, thank you so much. We have there are so many questions for you. Are you ready to answer questions?
Absolutely.
Great. Well, your presentation has inspired a lot of additional clarification questions and ideas. So Paul Marston would like to hear a little more about how these social service workers are mobilized and supported by the government, and how their activities and reach will be sustained by the government. So some questions about sustainability. There was also a question about how social service workers coordinate with the health extension workers and urban health extension professionals, especially in the catchment areas where they both work. Let's start with those two questions, and then we have a few more.
Okay, that's a great question, by the way. The training cost of $300 all inclusive. Yes, it's all inclusive after the accommodation, the tuitioning, and transport. And most of the infrastructure and the salary of the teachers and the classrooms, the infrastructure covered by the government. So we only actually contribute small amount, of course. And so this is just $300,000 actually, $300 actually more inclusive. Maybe for the future, I don't know, when the level is increased, actually it will be more increased. And the other question is, how is sustainable in the training program? I think it is it's not currently covered by PEPFAR. It is a course, we actually, the government, the lion's share of the course is actually from the government. And you can see that the government is ready to employ actually, and they are employed them. The teachers actually covered, the teachers are covered by the government. Additionally, the government actually incorporated these cadres in the work plan and in their work plan in the policy. So I think it's more sustainable. And the other thing is, Maureen mentioned that how they are coordinated actually with health extension workers. The health extension workers actually, they are working, they have 16 packages, more focusing only health related. And one health extension worker covers actually 500 households. So she cannot actually address the social issue and the social problem, and there are also households that should not be covered, that will not be covered by the one health extension worker. So they are working together, by the way, and the health extension worker now actually they can give tests at household level, and that's very challenging for them to provide adherence counseling, post-test counseling, and also loss follow-up. And referral linkage and other things are all covered by actually by this cadre, and they are actually work together, the social service workers as well as the health extension workers.
Excellent. Great. Thank you. Well, we have just a few more questions, Sagai. One question was about plans to build or expand in-service and postgraduate professional development or continuing education. I know that this workforce was envisioned in a way that would support kind of moving up a career ladder. So I think it'd be helpful to learn a little more about that and how that works. Also, there was a question about your retention strategy. So this is a lot of people to train and deploy. Are you worried about retaining these people, and how can you make sure that they stay in the job and that they are able to continue to work for as long as we need their services?
Okay, that's a great question again. So the future career actually very interesting, by the way. That's why actually we use the health extension module. The health extension module at the beginning, it was one of the very challenging things for their career development for the future of their career. Now the health extension worker actually they are nurse, some of them are nurse, so they can continue actually for BSc and also MSc and other things. The government actually creates the system. Here there is a level 1, level 2, level 3, level 4, and level 5, and there's MSW, BSW. So if they finish the level 2, they can continue level 3, and they can continue after they finish level 3, they can continue level 4, and also they continue up to level 5 and as university. So it is a very clear strategy for their career development. So that's interesting. There is no any question for their future career development. That is, by the way, that's one can help actually their retention, because if they can retain with the government system, they can continue actually. Of course, they can work from the CSO as well. And the other retention system actually, we are actually advocating the government to provide some incentives. The first thing actually, these are, some of them they were volunteers who have grade 12 and also grade 10, and now after they move to the permanent job to the government. That is one retention rate. Another thing is the government actually now is conducting a study actually to see how their incentive mechanisms for the future. The other thing is we will continue, the government actually continue to provide on-job training. That is another retention mechanism. Of course, retention is very challenging, but so far actually I don't think so. It's a very critical problem for this careers, because particularly people are very much interested to continue especially to continue their future career. So that is already clearly indicated in the policy and also in the implementation strategy.
Excellent, Sagai. Well, just one last question. So these, and just to confirm, these workers that you're talking about are salaried. They are part of the government workforce. And this number, 3,000 plus, that you referred to, is this the total that you believe is required within the country? And if not, how will you recruit and retrain more workers?
Yeah, I don't know if I could get your question carefully, correctly. The recruitment and for these social service workers, by the way, when they recruit these cadres. They are working with our implementing partners. They are working with the CCC. There is a community care coalition. They are found at the Kabale level as a low administrative unit. They are responsible most social service issues at the Kabale level. So there is the government body, there is CSOs, and there is actually the community representatives. And there is a clear checklist to recruit actually these cadres. And after they recruit, they actually propose to the colleges. And the colleges actually are working together at recruitment stage as well. So easily actually they can identify who is eligible, who is not eligible for that. And why the number is not a small number so far, as I mentioned that the government previously actually they are not actually aware about this issue. And they are actually they have a lot of priority issue on this issue, on HIV issue, because they believe that actually the HIV problem is actually solved by the health exchange workers, but not. They know that, and their capacity is another challenge. And other donors actually they were not actually aware, and also they were not actually push the government to allocate resources. Now the government, as I mentioned, for the coming years actually the government has a plan to recruit more cadres and also to deploy with each Kabale. We have more than, by the way, 6,000 Kabales, and if they deploy actually 2 per Kabale, they may need actually more than 15 or 12,000 cadres. So definitely for the future, they will. The government has a plan to actually to deploy more cadres and recruit.
Wow, so 3,000 is just the beginning. There's a lot more work to do, it sounds like.
Exactly, yeah.
Great. Well, Sagai, I'm sure that others will have more questions for you, so please keep your eye on that chat window, and if you want to talk with Sagai a little more about his work in Ethiopia or anything else, then you're welcome to do that in the chat window. I have heard that Dionisio is back online and that his microphone is working, so I'm hopeful that we'll be able to hear from him now. So we're going to take a step back in time and scroll back through our slides. All right, Dionisio, is your mic working?
Hi, Maury. Thank you.
Great.
You can tell.
Wonderful to hear your voice. Well, please tell us about what you're working on in Mozambique.
Okay, thank you. Good afternoon to all of you. I'm going to share the work that we are doing to support the Ministry of Women, well, the Gender, Children and Social Action, the new name after the new government. A little bit of background about the social services in Mozambique. The ministry is relatively new and it only receives about 2% of the state budget for its operations. And we have about 1,500 public servants, of which only 429 actually received some sort of training in social action or infant education. Mozambique has a population of about 24 million, and the ratio of social workers is about 16,000. The social welfare courses have been delivered through the Ministry of Health, where initially the social action was a department, and we used the MOH Training Institute, the Nursing Institute, to provide those trainings. From 1975, when Mozambique gained its independence, till 2004, only 477 social workers were trained, and this included ECD educators and social assistants. It's worth to note that from 1994 to 2004, there were no consistent trainings, and the trainings were done ad hoc. To respond to the major challenge identified in the field of social action in trying to implement our OVC programs in the districts where we operate, and also in discussions with the ministries, in 2009 we started having discussions, well, a bit before 2009 with the ministry, and we ended up providing support to the ministry through Deloitte. And the aim of this activity was to provide institutional capacity strengthening to the social welfare force in order to improve the mitigation of HIV negative impact on OVC and PLHIV. As USG, we spent a lot of time brainstorming with the ministry to see what would be the best strategy for this support to specifically to the HR department. And the ministry knew that its workforce was weak and did not have qualified and competent staff to implement their mandate of supervising, coordinating the care and support, and making sure that there is linkage between the health, the social action, health, and other relevant ministries such as education. So in order to document all this, we started with a field survey which also looked at the needs assessment to identify the gaps and prioritize which needs we would tackle on. And from that, there are some points that it's worth to share. We noted that the respondents to the questionnaires, which were the social workers in the district, they had some sort of training. 54% said they had some sort of professional training, so included some training that the implementing partners could provide in order to implement the activities. But overall, and you can see 73% in their own perspective, they understood that they didn't have enough training to implement or to do the work that they perform. And majority of all the respondents were 12th graders, and that was actually the same as the universe of social workers that we have in Mozambique. So after that, we established 2 technical working groups with local experts, academics, teachers, and sociologists, psychologists, and some social workers. And this was led by the ministry with coordination by our implementing partner. And they worked in the revision of the 2 main courses One was the social welfare, and the other the early childhood development technicians training. So the training that we looked at was more based on competencies. So each level would have its own exit, professional exit. So whoever finished the 12-month training could perform certain activities. We developed and provided facilitation guides to strengthen the teaching methods because it required different approaches to the trainings, and so we had to develop all these facilitation guides. It went through an accreditation process by the Ministry of Education as a professional and vocational training, and this was a year-long process, very painful, but very rewarding at the end when it was finally approved. We approved, once approved, we piloted the packages in Maputo province for 1 year, and after 2 years we decentralized all the trainings to 2 other regions. So we had 3 regions providing the trainings: Maputo, one in the center in Sofala province, and one in Niassa province. So some achievements. We first, and very important, we addressed the critical curricular deficiencies. All the training curriculums that we had for both social assistants and infant educators were outdated, did not have issues related to HIV, and we had to review them and ensure that they comply with the international best practices, and that was a good achievement, and the recognition by the Ministry of Education and its accreditation was also a milestone. So far from 2011 to 2014, we graduated 151 social action technicians, graduated 25 early childhood educators. We incorporated in an evaluation component to follow up on all those that graduated. After a year, a team could go and see what is the work that they're performing, how they feel their skills are being used. And now for this evaluation that is planned for this year, we are planning to actually incorporate some questions related to what is the perceived impact from the beneficiary perspective before they were trained, and now that they have trained technicians, also looking across other sectors, education and health. But mainly the idea was to look at how they're performing after the training, give some further mentorship to them. Another important factor is that the ministry at the beginning thought of having their own institute, which was not feasible given the resource. If you remember, I mentioned that only 2% of the state budget goes to this ministry, and there was no way that they could have their own institute, that they could bring staff from all the 148 districts of Mozambique to be trained. And we partnered. We went back, looked at in the past where they were working with the Ministry of Health, and we worked together with them to actually use the training institutes of Ministry of Health and have a coordinator from the Ministry of Gender, Children and Social Action to work hand in hand with the training institute directors to make sure that the trainings happen. Another great achievement, and we have been working hard on this, was for the first time ever, the ministry was allocated a budget for this year of approximately $31,000 US to invest in social welfare training. Still a long way to go, but it's light in the tunnel, so we are very happy to see that. Another important aspect is that when we started to think about the decentralization of the training to be close to where the individuals coming from the district could be, and also looking at ways to gain efficiencies and reduce the cost, we were approached by two provincial directorates, one in the center and one in the northern provinces, and they were asking for support for their own social action directorates. And we provided support to our implementing partners to actually go and do an assessment to see what the gap was, and they used a maturity model concept where they look at the different states of development of the institutions, and they brought up the gaps, and from that action plans were developed for identified and prioritized gaps of those directorates, which then they use as their tool to advocate for annual funding from the central government. And also we identified some key areas that in order to for these directorates to do their work properly and to ensure that all the management, all the planning, and also resource management of what they get from the central government is done. We did train last year 52 public servants in one province and 56 in another province. And this was basically a launch to the decentralized courses for our training in Mozambique for the social assistance, decentralizing and moving them from Maputo to the provinces. And we look into decentralize even further to have more provinces of regions providing training. Our vision for social welfare strengthening and the goals of 1999 to 90 people knowing their serious status, 90 adhering to medication, and 90 suppressing viral load. I think we are more into the adherence component and retention and care. We feel that if we have competent, qualified social workers, they can coordinate better the district level care and support among all stakeholders and fulfill their role of supportive supervision to community volunteers, which is they are in the forefront and they need support. Currently, they only get support from the CDOs or from the civil society organizations working on that. But we want to see more state social workers providing this support, especially if we think on sustainability. Improved referrals of malnourished PLHIV to access direct social assistance programs under the social protection. We think that at the district in Mozambique we have the social action and the health co-located, but the linkage between these two sectors is very weak and requires a lot of work. With competent and qualified social workers, we can get that. The other work is that they need to fulfill is to monitor and support the community committees, especially community child protection committees that are looking after orphans and vulnerable children affected by HIV to get direct social assistance program benefits. There are cash transfers out there that the government is providing for the orphans and vulnerable children and PLHIV, but very little people get access to those. And with that cadre existing and working properly, we can ensure that they get this support and they can be retained in care, and that will help the 90 goal of retention and in care. Also, we have a recent study from UNICEF on alternative care identified that from the 800,000 orphans and vulnerable children affected by HIV, 700 were in immediate risk of abandonment. We need to support them with alternative care, looking at that families, foster families. That to be done requires social workers available and knowing what their role would be to link up with the Minister of Justice to ensure that they can actually speed up the process to enroll children in foster care families. Despite all this success and achievements, there are some challenges. And one of them is that we need to work and advocate for increased investment in social welfare workforce to make a lasting impact to beneficiaries. We can do things now, and when PEPFAR stops, if nothing happens, if the government is not on board, we will lose all the investments that we did so far. So we will continue to work, and that is one of the results that we want to see. There is also a need to continue to institutionalize and push for ministry leadership to assure that there is a development of human capital for the social welfare workforce in the country. Also, to gain efficiencies and develop local solutions, we need to work with the government to decentralize the training, and especially partnering with the Minister of Education to institutionalize all the training curricula that we have and be managed and coordinated by the training institutes at all levels. There is also need to support other provinces to do their assessments and develop action plans so that they can use that as a tool to advocate for more funds from the central government. Plans for the future work towards a more sustainable state-funded approach with all trying to overcome some of the challenges I mentioned. Decentralize the approach, take the courses close to those that need them, and make sure that we reduce the costs at all costs. Advocate for increased state allocation of funding for social welfare workforce, and assist the ministry to strengthen institutional relationship with other ministries and other donors to make sure that we can have an integrated social work training and also planning and support. Thank you very much for your attention.
And thank you, Dionisio. Thank you very much. I am unfortunately, we're coming to the end of our time together, so I'm doubtful that we will have time to have a discussion together, but we do have a few questions for you, Dionisio. So perhaps you can respond to those, and then we can hear from Anita. But this has been a very exciting conversation. I am extremely encouraged by all that you have accomplished, and hope that we can continue to share our experiences and our successes and celebrate them together. But Dionisio, just a couple of questions for you. One, we want to see if it'd be possible to get copies of the curriculum and guides that you referenced, and also the 155 social action technicians that you mentioned. Are they public servants financed through the government budget? Let's start with those two questions, and then we have two more.
Okay, Maury, I didn't get, well, your first question, but I can respond immediately about the 151 social action technicians. Yes, they're all public servants, and they're financed through the state budget. So they were workers of the ministry without any formal training on social action. So they came to Maputo, they were trained, and some of them were trained in the provinces, and they're back to their positions, and they are being paid by the government.
Great. And the first question was about the curriculum and the guides that you referenced. I believe the training curriculum and guides. And is it possible to get copies of those?
For Portuguese speakers, I'm very pleased to say yes, I can share them. That is the problem. We have them in Portuguese and available to share.
All right, so they're available, but they're available in Portuguese. And then two more questions. Who manages the case files, and is there a central database through the ministry? And is there a technology component to this effort, to this strategy, using mobile devices to conduct intake?
Well, there are, at the moment, it's manual, and it's done at the district level. All the case files are managed at the district level, and there are several activities that are being undertaken. One, we at PEPFAR, we are providing support to the ministry to develop a framework and a system for monitoring and evaluation. And there, at this moment, we did the gap analysis and looking at the current status of what they, how they handle the data and the intake and the case files. And on the social protection side, DFID supported and still supporting the ministry to, well, the Institute of Social Action, which is the implementing arm of the ministry, to actually re-register all the beneficiaries, and they're actually using technology. They're using iPads to do the registration into the new system that was developed.
Great. Well, then just one final question, and this question had to do with the extent to which the training you described is linked with training provided by the Ministry of Health, and in addition, the types of alternative care that are provided in Mozambique, and how are those efforts complemented by family strengthening, and to what extent is the workforce involved in those efforts?
Great question. Well, the training, the social action training being provided at the Ministry of Health Training Institute, and at the moment it's managed by the Ministry of Gender and Social Action. There are some areas of overlap when it comes to access to health, and the need to for the social workers to know how to do the intake of the families and the linkages of that. But we also have nurses from the Ministry of Health and other technicians that are being sent to this training, and those who become well, in Portuguese we call social action, hospitalier social action, which basically they will be posted at the health site to do counseling, health counseling, psychosocial support. We see this happening in HIV wards where they provide HIV psychosocial support to and also counseling for ART adherence, counseling for testing also. So those are the areas. So the Ministry of Health is also benefiting somehow from this training because they're sending their staff to be trained and be posted to provide some more social welfare type services and also ensure linkages with the social protection component. In terms of alternative care being provided in Mozambique, it's more foster care. It's in the process. UNICEF is working on this very well, and there is a process with the Ministry of Justice to speed up the process to make sure that there is the process for adoption, but mainly for foster care, it's speedy and ensure that children that are in dire need to be placed in a family actually gets placed in a family. And there is a component of psychosocial support and also linkages with the community child protection committees to support the placement of these children in the family. But it's mainly placing children in foster care families. Naturally, in Mozambique, when someone passed away, the family members will go and take the children and live with them. But now we're trying to be more knowledgeable of the need to protect the children from that because some were exploited. So there is a process of ensuring that there is a proper process followed and to ensure that the children are safe and protected in those families.
Thank you, Dionisio. Thank you so much. Well, I'm sure that we have many more questions for Dionisio and Sagai and Colin. I feel like we've just started this conversation in many ways, but I do want to give an opportunity to Anita Sampson to leave us with a few final thoughts, a few final words, and then we will wrap up our webinar for today.
Hello, everybody. Thank you so much for taking the time to tune in to the webinar today. We're really pleased and very, very encouraged by the participation. And I do want to thank the presenters today, Dionisio, Tsechai, and Colin. It has been such an incredible learning experience for all of us that have been on the webinar listening to you. I just wanted to make some observations and some closing thoughts today. I think that I wanted to reiterate that the social welfare workforce continues to be an integral part of the HRH policy that the PEPFAR program is pursuing, particularly under PEPFAR 3.0. The social service workforce continues to be the life force in assisting people to access vital health and social services to stem the HIV epidemic. And I think we need to continue to work very closely with the governments that we are working with to increase the investment in the social welfare workforce to make a lasting impact on the beneficiaries. Retention and sustainability will continue to be high on all of our agendas. I think there were some very interesting points that were made. I think David said it very nicely when he said that the social welfare workforce is really the connectors. They're connecting people to services and they're making those services work for people. I see that throughout the presentations that have been presented today. That's been reiterated over and over again. And that our need to continue to invest in the social welfare workforce is a critical component as we move towards stemming the HIV epidemic, and particularly focusing on the placement of these vital social welfare workforce participants to ensure that they are in the areas of the highest need, mobilizing children for testing and working on ensuring that we provide adherence support where we can. And so with just those few minor closing remarks, I want to thank all our presenters, and thank you, Mari, for leading us through this. This has been very, very interesting. Thank you.
Absolutely. And thank you, all of you, for joining us today and for bearing with us and with our technical difficulties. I always think it's such a miracle that we're able to tune in from all of these different places in the world. I am amazed by what we've been able to accomplish in terms of workforce strengthening, but also that we're able to come together to talk about it. And finally, just if you would like to learn more about other events related to World Social Work Day, you can do so at the website on this slide. And then also, if there are any other events or opportunities that you would like to announce, unfortunately we don't have time to do that right now, but please do log on to the Social Service Workforce Alliance website and let us know so that we can tell others. And then also, if you're interested in joining the Alliance and you're not already a member and you'd like to receive notices about future webinars, also please do visit our website and register. And remember that a summary and a recording of this webinar, as well as each of the past 18 webinars, is available on the website. So thank you all very much, and have a very happy World Social Work Day. Goodbye.